So, hello everybody. Welcome to our first webinar. We will wait some minutes because not everybody is still in, so we wait 2 more minutes before we start. So feel relaxed, grab a glass of water or something, and we'll start in 2 minutes. Okay, so now we can start. So welcome to our first webinar today. First of all, I want to welcome you and explain you a little bit about how it works. As you can see here on the picture, please note that all of you are muted. That means when you want to ask a question, please use the chat function or the question function. So when this session starts, the GoToWebinar control panel will appear on your screen, as you can see now. And by clicking the small red arrow, the control panel can be minimized or maximized again. So send your questions to us via the question chat. That's the easiest way to do it, because when everybody is asked questions during the presentation, it will be stopped very often. So as I said before, please use the question or the chat function, and we will answer this question after the presentation. The whole presentation will take about 90 minutes. You are muted, and as I say before, questions are answered after the section, and please ask via the chat. And now I will give the screen to Dr. Fabian Quaisert. So Fabian, please feel free to share your screen.
Okay. Hello, welcome to this webinar. It's hosted from Germany, in the peaceful Germany, I think. I hope so. And first I have to share my screen. And I will check if I have the correct screen. I think this one is the one. It works. So if not, Kristen, tell me, okay?
Perfect, I see your screen, yeah.
Perfect, okay. Give me 1 minute to make it perfect so I can follow also the screen. So now I'm in. Yeah, welcome. We will share today a basic webinar with the topic urinary stress incontinence in men, and I will bring you information from conservative to surgery treatment. So it's a mixture of official guidelines and also a very personal way. So I will give you an overview about all these stuff, about different surgical techniques and implants, but I will also include some tips and tricks for you for using the devices and anything else, also for the conservative treatment. And I will also include my personal way, even for adjustable slings. That is the reason, because I have a very personal way to implant them, that I was invited to share this meeting. Maybe you know it, we will share this year 4 meetings. They are built up, so every meeting has a special topic around male incontinence. This one is a basic webinar. So I will start with a case from my hospital. This is one patient. He had before radical prostatectomy an 87 cubic centimeter prostate with urge dominant LUTs. He had also 5-time nocturia before surgery. Then a Da Vinci prostatectomy, a laparoscopic prostatectomy was performed, normal condition, and he had after surgery a huge urine loss of about 80% of his whole urine a day, about 1,200 grams a day and 400 grams at night. Then over 1 year, he has a lot of conservative treatments. He had a stationary rehabilitation, biofeedback, electrostimulation, anything else. And after 1 day, he received, because of a further incontinence, an artificial urinary sphincter. He had before the sphincter 300 grams a day and 50 grams at night. So the sphincter was implanted, even in an expert center here in Germany. But after the surgery, he was also suffered by severe incontinence with 4 pads a day, the same urine loss as before surgery, and also at night he had some urine loss. And he asked me for helping him to maybe perform our atoms technique or anything else. He has a normal urinary stream, he has a higher frequency, and he performed the daily pelvic floor training. So this case is a begin. I will go to this later. First, I want to show you something about the epidemiology of urinary incontinence. I know a lot of you cannot read this sentence, but it's a German examination and a German publication. And it's really good because you will know how many people will suffer by stress incontinence or incontinence after radical prostatectomy, because it was a really good study with a prospective follow-up, and all German centers, expert centers for prostate cancer, are including all their patients. So if you want to be an expert center and you will have the title of expert center, you have to bring all information from your patients before and also after surgery, a follow-up in a data center. And so we can really get to know what is happening with all these patients who were treated for their prostate cancer. It's named PCO study. And over eight years, the data were collected. Nearly 18,000 patients were included, and all these patients were followed up by the EPIC score. And also there's included some information and questions about the incontinence. And 75% of all patients had a 1-year follow-up. So we have information before the radical prostatectomy, and we have information 1 year after a radical prostatectomy. This is a really good overview about what happens after surgery. And before surgery, 88 patients denied to be incontinent, and after surgery, 52% denied to be incontinent. So nearly a half of patients are stating, okay, I am still incontinent after radical prostatectomy. This is a 1-year follow-up. And when looking to situation, the more severe problems, you can see only 3% of the patients stated that they have more often than once daily a urine loss, and 21% of the patients stated this after surgery. But I think these are not typical patients for our expert centers for male incontinence. I think the next amount is really necessary or really interesting. This is 5% of patients who will suffer by over 3 or more pads a day, and also who are stating that they are really affected by urine loss and they have a huge problem with this. And I think this 5% is a really good number. This is the number of patients who are 1 year after surgery relevant incontinent, and this is our typical treatment cohort. We will see. But we have to say one thing. We have a lot of information about this, but we do not really have a lot of information. What is the reason for this incontinence? And now let's go back to the case. I'll highlight it in blue. We have before radical prostatectomy, urge dominant LUT. We have 5-time nocturia. Even after sphincter implantation, we have a 5-time nocturia and also 5-gram urine loss at night. And this is what I will show you the next slide. First, what I've done, what the experts from the other center didn't before AMS 800 implantation. I performed urodynamic in a standing condition. And what I could see, the patient was in standing position, has the 8-French catheter inside, and the sphincter was deactivated, so it was open. And what we can see is a really good urodynamic approval, overactive bladder with motoric diffuser contractions, and urine loss because of this urgency. So this patient has an overactive bladder and not a stress incontinence. And for all of these studies, the epidemiologic studies with questionnaires are investigated. You have only information, you have a urine loss, but you do not really know is it an urge dominant or stress dominant urine loss. So there's one number for us surgeons, which is interesting, is the number N, the patients with relevant stress incontinence. And this number is about 5% minus all patients with a dominant detrusor overactivity. And this axis somehow known. There's one publication I recommend to read. This is one overview about patients with bladder dysfunction after radical prostatectomy or prostate treatment. And this meta-analysis shows numbers between 2 and 63% with a motoric overactive bladder in their examinations. So I think the real number is something between, in my feeling, in our hospital, we have about 30 to 40% patients who have a more dominant urge incontinence than stress incontinence who are coming and interesting for a sphincter or anything else. And we have to account this in our diagnostic and also treatment path in the future. So let's go especially to the stress incontinence, and I want to show you who patients are at risk. And I liked this study. It's okay, it's 8 years or 9 years old, but it's really interesting because we have only one surgeon and he performed 4,000 radical prostatectomies. And with this data, they try to find out which patient or which condition of patients before surgery makes them more stress incontinent than others. And the control group is 95% who are continent after 1 year. You see again, 5% of the patients are more incontinent. So 5% is a normal number, I think, for still incontinent patients after 1 year. And we have some variables who were associated with a poor outcome. The first one is a BMI above 35, with only 88% patients who are incontinent after 1 year. Older patients are more incontinent, with about 15% incontinent patients. Also, the big prostata size makes it possible that they are more incontinent than small prostate sizes. Above 80 milliliter is here the threshold. Also, the prior TURP is associated with a higher incontinence rate, with about 82% incontinent after 1 year. And as already known, the radiotherapy is really a problem. So in patients with a salvage prostatectomy, we have nearly 50% of patients who are still incontinent. All these numbers are a mixture of stress incontinent, urge incontinent, and a mixture of both. So always be aware that you can also have an urge dominant situation. When looking to the transurethral procedures, I like to present this one from San Antonio as presented, and all, as I know, not already published official, but really good number because they use the Pearl Diver Marina US database. It's a huge database where you can commercially available data, you can buy them and try to investigate them. And they examined different procedures for benign prostate hyperplasia, and they found about 2.6, 2.1 for a big prostates with whole lip procedure and tulip procedure. This is the most efficient, and I think the new gold standard for prostate hyperplasia. So this is a higher amount compared to TURP, where we have only 1%. So in my opinion, is we have a decrease of patients who are severe or moderate incontinent after radical prostatectomy because of the robotic approach. And this number is equally with the increase of the numbers after prostate, after benign treatment, because we see an increase of incontinent patients even after whole lip or tulip. So I think, in my opinion, we have the same amount of patients in the last year, and we don't see decrease after the dominant radical prostatectomy with the Da Vinci system. What is the reason for incontinence after benign hyperplasia? I think we have three different situations or conditions, and sometimes it's a mixture of all of this. The first thing is, I think nobody of the surgeons who are working this properly and do it a lot are cutting directly the sphincter with a laser fiber or anything else. I think typical is a trauma below the symphysis. So you have some angle where you are moving your instrument, and I think we can see somehow destroying of the sphincter and the apical position below the symphysis. This is a thing you can see when you're looking inside. You can see a scared apical sphincter, and the lower part of the sphincter is looking healthy. But we have also a lot of patients who have a complete loss of bladder function because of an obstruction. So the bladder is destroyed, it's a hypercapacity. You have a lot of trabecals. You can see that there's no really sensory situation. And in some patients, you have also endothelial overactivity, also dependent on a long-term obstruction before. So it's always a mixture, and this apical sphincter trauma you can always, or you can often see during cystoscopy. In radical prostatectomy, we are talking about two different time slots. And the first time slot, the first year, is the early incontinence. It depends on a delayed adaptation of the external sphincter, and also you have some patients with an urgency because of the trigonal preparation and suture. In that situation, you have to wait, and we know that a lot of patients are suffering by conservative treatment and don't need any surgery after. And it's compared or divided by late incontinence after 1 year, where you can expect there's a problem. Yeah? This is not only a problem of adaptation or of training or so. You have, in one case, you have relevant sphincter damage, neurogenic damage. Maybe you have a lot of patients who have a loss of bladder or sphincter perception. They don't feel it, they don't know how to do it because the bladder is destroyed and doesn't say the sphincter how to do. And you have also some patients with an overactive bladder. And so we have to divide the treatment in two phases. And let's go first to the early incontinence situation, the first phase where you maybe see some patients. I have to go back to the anatomy. Let's take a view at the rectus sphincter, the external sphincter, who is responsible for the continence after radical prostatectomy. The inner part has circular smooth muscles. It's partially innervated autonomically. And you have an external part with a U-shaped sphincter. In the apical part, it's very thick, and in the dorsal situation, it moves into the wave. So the most sphincter parts are in the apical part of the external sphincter. And let's take a view inside the histological situation. We have a combination of fast twitch fibers. The white muscle fibers are named so. So when you're looking to a microscope, you see they are more white. And you have about 30% only slow red muscle fibers. These are the slow twitch fibers. And they are completely different from the function because the fast twitch fiber can move very rapidly and have a great strength, but they get tired quickly. So you cannot move them or contract them over hours, just for a few seconds, maybe 10, 30 seconds, and not more. And we want to have the red, slow twitch fibers. They have an endurance performance. They are needed for the basic continence, and this is the part of the muscle we want to increase over the months to get the patient continent. And once more, it's better visible. These are the fast twitch and the white fibers, and this one we want to have. We want the slow but really endurance fibers, the red slow twitch fibers. This one we want to have. So the treatment of choice in this situation early after operation is not to make this. This is not the best way because you are only training the white fast twitch fibers. What we want is we want an adaptation. The patient have to repeat the training, but not with a strong tension. They have to repeat it with a very smooth training, not to contract too much, also not to contract the pelvic floor. They just have to imagine the sphincter. They have to connect the brain to the sphincter to make to bring something like a reprogramming of the sphincter, and then it's changing from white fibers to the red fibers. And to do this, you can help the patient. So typically, I tell my patients after radical prostatectomy, you can come back to me when you are further incontinent after 3 months and you don't see any progress in your continence treatment. Then they're coming back, and I will demonstrate them their own sphincter function. And I recommend to do that. It's a biofeedback cystoscopy, and I can show you one patient who was sent me back for making this. You see the bladder is looking really normal. We are in anastomosis. Now you can see the sphincter in this place. Sorry for the German speaking. It means the external rectus sphincter in male. And what we see now is different contractions. The first one is a pelvic floor contraction. You can see it's a contraction from the pelvic floor muscle. It makes something like a huge tension on the urethra, but it's not responsible for the continence, because you cannot close the urethra completely only with an external contraction. What we want to see is this internal contraction, and this is a thing I can show the patient, so they try to avoid this strong pelvic contraction and go more in detail to find their own sphincter. So the biofeedback urethoscopy is really helpful in this situation, and I recommend to do this in patients who are further incontinent and do not see any increase of continence situation. So after treatment in the first year, we want to see more red fibers and a low amount of white fibers after that. And it's also really good known, and I think everybody of you will recommend that, your patients, that they have to do a pelvic floor training. But the question is, should we do it also before surgery? Here's one working group, they tried to do it. They had 90% who are doing pre and postoperatively a pelvic floor training, and 90 patients with only postoperative training, and they didn't find any difference. So I do not really use this pre-operative approach to naked training before. I think males are often really well known for doing it too strong, so we have a really strong tension, and it's not a good way. I think we can start after surgery as well in this situation. And for the postoperative pelvic floor training, it's well known that you can see a higher and faster continence rate. You see the blue group is the situation with the pelvic floor training, the red group is without. And what we do not really know is what is the end point. Yeah? In my opinion, the pelvic floor training after surgery makes it helpful or brings you faster to the continence situation. I'm not sure if you have at the end, after 1 or 1.5 years, a different amount of patients if they are doing training or not. It's not really known. I think you have an acceleration of the continence in the first month, but at the end, I'm not sure if you can see it. But it's a EAU guideline level of evidence 1, so you should do, and I think it's okay, and it's not so difficult to do it. So the patients want to do something. You can also add some devices. For example, biofeedback and electrostimulation. For biofeedback only, you have inconclusive results. The level of evidence is only 3. And for the combination of biofeedback electrostimulation, it's a level of evidence 2. It can be done, in my opinion. I think males are happy to do, so you can do this. And I think it works good in patients with a low incontinent volume, so a mild incontinent patient. But in patients with a moderate to severe incontinence, I'm not sure if it's working. I like to do biofeedback cystoscopy. I like to show them that their sphincter. It's much more efficient, and then just do electrostimulation and putting something in their ass. So you can do it, but I'm not sure if it's really helpful or brings patients from a really problematic incontinence to a good situation. And of course, you have the ability to make a prescription for duloxetine. It's a serotonin noradrenaline reuptake inhibitor. It's well known as an antidepressant, depression medication. It leads to increased activity of the pudendal motor neuron, and I think it's well investigated. We have randomized controlled trials, and we have also some case collections, so it works really well. I think somehow better than in females, in my opinion. The dosage is about 20 to 80 milligram a day. In Germany, it's not official recommended, but we use it in individual cases for sure. But we have to discuss before, because it's we have a high amount of side effects. Gastrointestinal diarrhea, constipation, nausea can occur. We have adipositas may occur over a long time treatment. And the biggest problem, I think, is this change of the character. The people are getting restlessness. They have a sleep disorders, nightmare, anything else. So, in my opinion, I have a rare amount of patients who are doing it long term. We have really a high amount of patients who try it to say, okay, it's helpful, but after a half year, they're coming back and want to have a surgery because they don't want to take medication all this time with all these side effects. One examination or one exclusion is I have some patients who have a coexistent depression or neuropathic pain. In that condition, it works perfect because you have a treatment for both conditions. So depressive patients, and a lot of males in my ambulance are really depressive after having cancer without prostate, no potency, they are impotent, and a lot of things which make them reactive depressive. And in these patients, it works really well. So I think all patients who are doing using duloxetine and do it long term are somehow depressive and like these both effects. So in that conditions you can do. Then don't forget once more, we have some patients with an urge dominant or relevant situation with the TRUSA overactivity. In this condition, you can use oral medications, antimuscarinics or sympathomimetics. You have to be aware in patients with radiation, it's not working very well. We have a decrease of evidence. But what we really can do, and it works unbelievable great in people after radical prostatectomy, is the injection of Botox. Normally, the males are somehow below with results after injection therapy, and we know it from a lot of publication that the problem is the residual urine. You need catheterization. Even in old patients and males, and patients after radical prostatectomy are old and they are males. But we know, and it's well known, that these are only patients with a relevant, significant subvesical obstruction. And then after radical prostatectomy, you don't have an obstruction. You have an BOI of -20 in typical cases. So the patient is completely open. So in that cases, it works really well to perform Botox. And I think it's better than in normal females, for example. So patients after radical prostatectomy, you can really perfectly try Botox. It works well without nearly no side effects. So now let's talk about surgery. I think most of you want to hear something about that. Before that, we have to talk once more about diagnostics. We are using a lot of things in our ambulance to prepare surgery, and it's really important to do some of that you understand what the patient problem is, because the correct indication is absolutely mandatory for a good result. Even when you don't have urge incontinence and you only want to implant sphincter, a lot of centers are doing that. They don't use slings, they only put sphincter inside. You can do it, but especially for slings, even fixed sling or adjustable slings, you have to get some knowledge about the condition before you perform surgery. First thing is I recommend always to use a 24-hour PET test, because you have patients with 10 PETs a day and only 20 gram urine loss, and I have patients with 500 gram a day and they only use 2 PETs. So it's really depending on the PET size. So I always recommend use a PET test to get real knowledge about the volume, the incontinent volume of the patient. Then in all conditions, you have to perform sphincteroscopy to understand the condition of the sphincter. I will show you examples in the next slides. Also, cystoscopy, you can exclude obstruction. You can see some problems with bladder, trabeculation, low capacity, and anything else. I always do a standing cuff test. If I see a healthy sphincter and the standing cuff test is negative and the patient has a urine loss of 300 milliliter, I go on with the urodynamic to understand, because it's a mismatch between a negative cuff test and good sphincter condition in cystoscopy. So the combination helps me to exclude patients who have maybe neuropathic conditions or maybe bladder dysfunction as a reason for incontinence. All patients, when they are going to our front test, asked for perform uroflowmetry. We get some drinks. And if the patient says, no, I'm not able to do because I'm fully incontinent, it's an information which helps me, because this patient maybe goes more to an artificial urinary sphincter. When you are not able to sit down to drink something and then go to the toilet, it's difficult in that cases to use a sling. I will show you later more information about it. And as I told you, in some cases, not in all, I use urodynamic. It's about 1/3 of my patients. Two reasons I have. The first one is a mismatch between standing cuff test and sphincteroscopy. And the second one is when I expect a complete disturbed voiding. When I see a really pathologic uroflowmetry with 8 milliliter and a lot of voids. In that condition, I perform urodynamic to understand maybe also bladder disturbance. And I recommend to do it in a standing position, because you can really good see, you can objectify stress incontinence, and you can also see a urine loss and urges, as I shown you before. So this is my approach, this combination of diagnostics I use in my patients. And then going to the devices. First of all, a lot of people think, okay, the first one was Scott sphincter, 1972. This one was the first device, but no, the starting was slings. So Barry sling is the first one, 1961. It was an acrylic block. It's a really hard device, like stone, was placed under the urethra and just sutured on the urethra. It was the first try. This is not working well. And the Kaufmann sling, it was 3 times adapted, and they added some devices and some tricks of the Kaufmann sling, which was implanted in about 80 patients in the early 70s. It was connected with a small silicon reins, and you have also a polyurethane cushion. It's better comfortable. It's not so stone. It's something like warm plastic. You put it inside. Both were placed on the urethra. So really interesting. They are not far away from things we are doing now. And you have the Scott sphincter. It was developed 1972 from Brantley Scott. It was the first artificial urinary sphincter, and for the next about 25 years, it was an absolutely dominant device. It was a gold standard for incontinence, and these links were for 25 years never done worldwide. So really a strong period of sphincter implantations, but now we have much more implants. We have 2 things to decide, and this is an overview. We have the artificial urinary sphincters, AMS 800 already available, but we have also new devices like the Saphir system with a big pump to use it for more old patients with a disturbed finger sensitivity. And we have adjustable Victor sling. I think the results are comparable. I use the AMS 800 because of the ability to adapt situations. I can use 2 cuffs, for example. I can change cuffs. So I always go on with AMS 800, even because of the fact that all devices are nearly comparable. So I will change my device when I know other devices are better than the one I use. And for the slings, we have a lot of, we have Argos, we have Remax, we have the fixed slings and Atoms. I will go on later to show you which are in each system is available. I don't want to talk about collagen injection as off-label because the guidelines say don't use it. There are some cases where I see a really small scar, a small opening of the apical sphincter after QRP or enucleation technique, but a small amount, about 1 to 2 patients a year. Sorry. And ProAct, I also don't use it. I think it's quite interesting, but we have a really much too high revision rate of above 40%. Because of movement of the balloons, they're hiding away. We have a bladder neck erosion in some cases. So in my opinion, with the availability of adjustable slings, it's much better to use this device and not ProAct balloon. What wants the patients? They want to have passive slings. It's an old study from Kumar, but it's really interesting. They were only asked, so there's a small explanation what the device are doing and how they are working. And 92% of the patients want to have passive slings. They don't want to have artificial urinary sphincter. Only 8% of the patients wants to have them. I think most of them are engineers, something like males who like to build something, and the normal patients just want to do something. They want to go to the toilet and just pee and nothing else. And we have to use this information. So we should, in my opinion, we should do what the patients want if possible. And we have more reasons to decide in this way. What are the guidelines? The guidelines are telling us you should implant artificial urinary sphincter. So we have only recommendations, weak recommendations for the fixed sling in cases with mild to moderate incontinence patients. And the statement is also that there's only limited evidence for adjustable mesh slings that they can cure or improve stress urinary incontinence in men. I think it's really funny because everybody who is using adjustable slings in a manner like me, with atoms, for example, knows that it's able to cure and improve stress urinary incontinence much better than fixed slings are doing this. So I think the guidelines are a little bit old in that situation, and I think the guidelines will changing in the next years because of some really interesting things who are going on in the future. But the only strong recommendation is offering artificial urinary sphincter to men with moderate to severe stress incontinence. And this recommendation has to be discussed. I will go on later because we have really good informations and efficacy for a sphincter that shows that it's not maybe a good idea when you have both options to use a sphincter. I will go on later. Wait for it. Let's talk before I go to the different devices about the stress incontinence severity. We are talking about mild, moderate, and severe patients. I think the mild one means they have a leakage only during hard efforts, long hikes, for example, doing coughing or sneezing. And typically, you have a worsening over the day. So in the morning, they are still incontinent, and over the day, when the sphincter is more and more used over the day, it's worsening. And the pet weight test should not accelerate above 400 grams. So normally about 100 to 200 grams are typical mild incontinent patients. Then we have a moderate situation above until 1 kilogram urine loss a day and more. That means you have a urine leakage even during simple movements, walking, or prolonged standing. So it's something in between severe and mild. Severe means you now have urinary control. You have a heavy urine leakage even at night. And it's not easy to perform spontaneous micturition because you have so sphincter disturbance that you are not able to. And I think these patients is it's the biggest amount of my patients. So I think this one about 30%, this one about 10%, and this is about 60% of my patients. So most of the patients have a moderate incontinence between 300, 400 grams and 1,000 grams a day. First view to the fixed sling. It's the smallest thing we have. We don't have silicone used. We have only a mesh inside. It's really good used in investigated for mild stress urinary incontinence. The patient should be completely continent at night, and you should avoid to implant it in patients with radiation. In this condition, it's not recommended. We know it's from some studies that about 25 of the patients are continent after advanced XP and radiation. About 25% have an improvement, above 50%, and 50% of the patients are still relevant incontinence. So I would not do, because we have other options. Cystoscopy or sphincteroscopy should do. You should see nearly a healthy sphincter. You should see a normal functional length, so no scarring inside the sphincter. And maybe you know the Goatsy test or positive reposition test. That means that you are pressing behind the bulb. So you are pressing your finger or something like a swallow behind the urethra, and what you can see is a reflectory contraction of the sphincter. When you can see this reaction doing this test, it's a perfect patient for advanced XP, for example. And I told you I always use uroflowmetry for the patient. The patient should be able to go to uroflowmetry, and you should expect a normal voiding. When you can see difficulties with voiding, you should maybe be careful, because you are changing the compression situation. The sphincter is a little bit obstructive after surgery. So in this condition, then you have maybe an acontractile detrusor, you will see residual urine and maybe also problems to void. For the implantation, maybe you know it or not, we have to open the perineum. We have to open the musculus bulbar spongiosum, so we see the urethra completely. You have to connect the mesh on the urethra. You have to perform an outside-in technique approach. You take the mesh from, inside-out approach. You take the mesh from inside out and fix it. And after, this is the situation inside surgery, and after then you are pulling the mesh. You are putting the mesh inside, and you are elevating the urethra inside the pelvis. And what you're also doing, and I like really this idea from Peter Rieder, you are doing like a blood stasis in the urethra. So you are placing something like a hammock between the sphincter and the urethra. And in this situation, you have also an assistance of the sphincter. This is maybe the reason why you can also do it in some cases after TURP or enucleation. If you have only the elevation of the urethra works, it would not work after benign prostatoplastia treatment. So I think it's a mixture of elevation and also something like building these swollen corpus behind the sphincter. For the evidence, we have a lot of studies with a long follow-up. The average urine loss before surgery was 270 grams. In this over 100 patients study, 64.9% of the patients became dry. I think this was social dry. That means 0 to 5 grams were named as dry. 31.6% were significantly improved. That means a reduction of 50% or more urine loss, and the average urine loss was 32 grams after surgery. Complications were rare in this situation with a 3 years follow-up. 2% urinary retention, 2% de novo urgency, and below 1% with consistent pain, which has to be treated with medication or in some cases also with explantation. This is a 5-year follow-up from the same cohort. They started with 115 patients. Now only 59 patients were further included in this follow-up. And we have over the time nearly 2/3 of the patients who are nearly cured, about 23%, 25% were improved. And we see a raise in failure groups. So a lot of patients with advanced XP implanted 10 years before are coming now to the hospitals and ask for adjustment or further incontinence surgery because of an increasing incontinence over the years. And this is well known that after 4 to 5 years, the number of again incontinent patients is really increasing after advanced XP implantation. Then the second group, and I told you this is the biggest group in my hospital, are patients with a moderate to severe stress incontinence. They can be incontinent at night below 50 grams if you have a more urine loss, whether you have a complete sphincter destruction, which not works with adjustable sling, or you have to think about overactivity in that patients. The patient, one of the most important statements is that the patient can reach the toilet continence. So he feels the void, he is standing up, he don't use his fingers to close the penis, he just go to toilet and is able to void spontaneously. This you can also try in your office to send them to uroflowmetry. And one information that's really perfect after this obstruction, I have nearly 100% treatment efficacy after TULIP, HOLIP, or TURP, with a really good condition for these special patients. You can also put it in irradiated patients. We have a gap of about 10 to 15% lower efficacy or lower rate of dry rates, but it works. And I think the radiation situation is the same for all devices, even for the sphincter. You have a bigger gap than 10% between irradiated and not irradiated patients in sphincter after sphincter implantation. Then performing sphincteroscopy, you can see typically something like this. The sphincter is open, something like that. The patient is able to contract the sphincter. I ask the patient, please contract here. And when I can see we have an internal movement of the sphincter, he is able to nearly close the urethra. I think in this condition, I would implant an ATOMS as well. So I want really to see this active contraction. And when we cannot see it, you should not perform ATOMS. In some cases, it looks like this. You can look inside the sphincter from the distal urethra, it looks well, and then you go inside after 1 or 2 millimeter, you can see a scarring of an irradiation patients, or you have a scarring of the bladder neck. So when you have only something like a short visit of the sphincter, and behind you have a huge scarring, you cannot see the contraction. This is also a condition where I would more use a sphincter and not an ATOMS in that case. And uroflowmetry can be performed or should be performed to exclude acontractile bladder. We know it that patients who are acontractile, where the tooth is acontractile, and the patients who are using a belly press to void have a lower outcome, poor outcome, with about 20% lower amount of patients who are social continent after surgery. So this mixture of all information, the anamnesis, able to void at night or in your office below 50 grams a day, with good sphincter condition during cystoscopy, and an exclusion of acontractile detrusor brings you maybe to implant an adjustable sling. What for slings do we have? Remake system, it's a small mesh which is connected with Prolene sutures, and you have something like a screwdriver you have to turn to adjust it. I make it short, you will see. And we also have Argus as a silicone cushion below the bulbar urethra, and you have something like this tension silicone stripes that you have to pull. And by pulling, you can adjust the advance, and you have this spacer to fix it. Also really difficult because in both conditions, in Remax and Argus, you have to make a small skin incision. You have a risk of infection. You have you have difficulties to do it. You need time. You need a surgery room. It must be sterile, very sterile. So in my opinion, it does not really be very good. So the first two are just classic IOST. The both variants, retropubic and transobturatoric, and also remakes, are working nicely in some cases, but we have this really difficult adjustment. We have a higher revision rate, and also in comparison studies between atoms and maybe remakes, we know that atoms has a better outcome with lower revisions in that case. So I think not only, but really important, is this really easily approach to adjust. Just a small injection of the port makes it so easy to adjust it, and some special tricks and technique during surgery, you can place it really near the sphincter. So I think this one is one which works really well. The Valco system is quite interesting because you have a small cushion. It looks like a little bit smaller than the atoms cushion. It's a retropubic approach, and you have also a small port to inject. So interesting, but it's only available in Argentina, as I know. So for Europe, you don't have the MDR approval, and I think also worldwide we don't have the approval. Actually, it's only available in South America. But let's talk about atoms, because A.M.I is providing this meeting, and atoms is, I think, the actual best device in the adjustable sling cohort. Atoms is placed below the urethra. It's completely fixed by the bone. You don't have a movement. The patient can stand up very easily. They can move what they want because you don't have some loose fit of the slings. It's really good fixed, and this is a really one really advantage of atoms SSP. And you have these small silicon covered scrotal ports. I place it between the testicles. It's better comfort, and it's really easy to adjust. I want to show you one meta-analysis for atoms, where we can see we have a good dryness rate of 67% and improvement rates of over or of 90% with over 50% reduction of the urine loss. And the interesting thing is that these results are included all systems of atoms. We have the old inguinal port system, where we have a lot of port erosions and difficulties, also with pain. And using all these devices, we have really good results. We could see a decrease of PETs from 5 to 1 after adjustment and surgery, and the PET rate decreased from 530 gram to 30 gram after surgery, with a follow-up of about 1.9 years. And this is one really big advantage of adjustable sling atoms. We have a low revision rate of about nearly 6%. This is really low compared to the sphincter, where we have a lot of patients where we can use both systems. So I think this is for the economy, it's the cheapest one. You can implant it, the patients are happy, and you don't need revisions in that amount compared to a sphincter. And these results are not the end of atoms. I think we have the ability to improve these results, and I want to make a short step to our proximal technique. This is a picture I showed you before, and I adapt this technique to implant atoms in the proximal position. Maybe you know it from advanced XP, where this sling is rotating behind the bulb. And I have a technique where I cut the central tendon. I try to rotate the cushion behind the urethra, and I have a really near placement of the atoms cushion below the sphincter, and I have nearly also sphincter, direct sphincter compression with this device. I can prove this statement when looking to the X-rays we are performing in patients who have been operated with atoms. Lithography, I used contrast solution in atoms, and I also perform lithography. And though you can see, this is a standard implantation technique. We have, it's something like hiding away, so the bulb is not supported. Here's the sphincter, it's far away from the atoms cushion. And this case is truly a continent patients after atom surgery. You can see the atoms is rotating behind. The direction is to the proximal bulb. And what you cannot see is any obstruction also, and it works properly because you have something like a mixture between the fixed sling and adjustable device. And if this patients will be something like a fixed sling cohort, be again incontinent after 5 years, I can adjust 2 milliliters, the patient will suffer. So I think this proximal placement of atoms makes sense and makes atoms much better. And I think in the future you will see that the results bring more and more adjustable slings in a dominant role in the male stress incontinence treatment. I'm happy to present this also in London next week at the EIU. I know you know this picture, and I presented before, and the results I would go on later. But first, I want to show you something. It's very important because this was really demanding cohort. We have a cohort with about 44.7% radiation people. So a group where we know that we have much poorer results in all sling types. And also we included about 14 patients with urodynamics. From this, from them, 11 had an overactivity also. So I think it's not an easy cohort. It's a cohort with a really demanding situation. And despite that, we have, let's take a look to the happiness. This is a PGI-I. This is question, how much do you feel better after surgery? And the PGI-I very much better or much better was stated from above 90. I'm sorry, I have to take a look at PGI-I. I go to this place, nearly 90% of patients stated that the situation is very much better or much better than before. When looking to the PET test, yes, we have 80 gram in average, but we have to take a look on this side. This is the PET weight after surgery and before surgery. And what we can see is the average is a little bit difficult to interpret because we have 2 cases, they are outliers with 600 gram and 1000 grams. So I really, special patients, maybe I had to implant sphincter better. But most of the patients are really with a low amount of incontinence. So what we really know is that we have a high amount of patients who are happy with the device. And we have only 1 revision to perform because of a direct infection of the device and patients with cortisone usage. So I think good data for the proximal technique with a really huge amount of happy people, and we want to have happy people. And this is what we can get with atoms. And also one more information is the bladder emptying. Some experts are saying adjustable slings make compression and obstruction. The people get difficulties to avoid. We have secondary overactive bladder, and what we can see, the IPSS is not changed. So I think we do not see any disturbance of the bladder emptying in this proximal implanted atoms patients. So I think good results, and it's a good reason to do this approach when you are starting with atoms and not the standard approach. And I want to show you last time this video. This video is a patient who had become an atoms. Before he had a TULAP, he had retention after atoms surgery because of loaded user contractility. And what we have done is we removed all the liquid from the device and we adjusted the system to 0 milliliter after surgery. And then 4 weeks later, the patients come back and we adjusted because of going on incontinence with no disturbances of the bladder emptying. And what we can see now is the device is in this condition empty. You can see over there, I'm sorry, I take a laser pointer. Over there is the sphincter. And here is the proximal bulb, the dorsal bulb wall, the bulbar wall. And I can show you what's happening when we fill in 7 milliliter. You can see the atoms device is moving towards the sphincter, and over there now the sphincter is closed. And this is not a complete closure of the sphincter that you have an obstructive voiding. When the patient tries to void, this one is opening and the patient can void really spontaneously. So this one looks as this one inside during cystoscopy. So that were all statements about the proximal technique, and we can go on to talk about it later if you have questions about it. Let's talk about the last group, people with severe stress incontinence with no sphincter control need an artificial urinary sphincter. So a lot of people are thinking about to use atoms because they want to have one device and use it. I think you need both. You need a sphincter and atoms device because some patients, a lot of patients needed a sphincter. So I told you about 30% of my patients has to become a sphincter, and about 60% of the patients can have an atom. So without sphincter, you have problems with some patients you will see in your office. Doing sphincteroscopy, if you see patients like this with a really scared bulb, it's a wide scared situation, you have some scarring in the sphincter, you have to press or to push a little bit forward to go with the stethoscope through the sphincter. You can see no active contraction. In this case, it makes no sense to implant an atom. So in that case, I really commend to implant an artificial urinary sphincter. For a sphincter implantation, it's important that the bladder function and also the bladder capacity is normal. Normal means above 150 milliliter. There's really good evidence for problems with patients with a lower bladder volume of 150 milliliters and below. So yeah, it's very important. And this is really a good knowledge. Voiding is irrelevant. So when you have patients with an equinterctile detrusor, no activity, you can use a sphincter because when you open it, you don't have any disturbance of bladder emptying. So in this condition, I would recommend to use a sphincter. We have different devices. I didn't include Rigicon. It's a new one. Former employees of AMS are moving to Turkey and build something like AMS. We have the Victor system. It's newly adjustable through a scrotal port. The pump is supported easily. As known, some colleagues are telling me that the results are comparable. You don't have a higher amount, and the adjustment is not working as expected, let me say. And the Sapphire system from ZSI is really good for people who have disturbances by palpating the pump, but it's a rare condition, I think. I use it mostly because I would like to combine it with the double cuff, for example, which is not able to do with Victor and Sapphire system. And when talking about the efficacy of the sphincter, I like to pick this study because these are real world data, and we don't have to deal with expert data from US center. We have to deal with the real world. And this is an observational study from French healthcare system. So all patients who received prostate treatment and artificial urinary sphincter were included, and we really good know what's happening with them. 5 million males were included between 12 years. Of them, nearly 800,000 had a BPH surgery, and about 266,000 had a radical prostatectomy. And really interesting is that the AUS implantation was performed in 1.8% after radical prostatectomy and nearly 0.3% after BPH surgery. So nearly every 5th patient after radical prostatectomy has to become an artificial urinary sphincter. So really interesting, this amount. But much more interesting is the next slide. This is a slide with a revision situation, and that are numbers or counts we have to deal with when discussing with the patient what to do. They have seen revisions in 29% of patients after 2 years. So every third sphincter, nearly every third sphincter has to be explanted or revised in the first 2 years. 43% after 5 years, 60% after 10 years. So when you implant a sphincter, you know that in a lot of cases you have to revise it. So this is, for me, very important that when you discuss with the patient and you have the ability to implant a sphincter or adjustable sling, I would always recommend to implant an adjustable sling because the low revision rate, when you implant the sling and it works lifetime. Yeah, and the sphincter condition, you have to have revised it in a lot of amount, and this is what we have to deal with. And these are numbers and counts which are really openly talk about with patients. I do it, and so when comparable, I would always go on with implanting adjustable sling. And when looking back to the guideline statement, they are recommend to use an artificial narrow sphincter in moderate to severe stress incontinence. I'm not sure if this is true or should be taught with patients in that manner. I think not. Revisions are performing to cuff changement or because of erosion. Erosion rate depends on center and time point. It's between 8 and in some cases even irradiated patients without a disaster up to 30% of the cases. So sphincter makes sense when it's necessary and nothing else works, but when you can use both, please go on with adjustable sling because it's much more easier and safer in that cases. This is one case with erosion. We have two different conditions for erosion. The first is the intrinsic erosion. It's usually occurs in the first 2 years. It's mostly dependent on the too tight cuff choice. So I use, when I have urethra of the small diameter, I use better two cuff with a higher diameter to avoid this erosion, or I use the transcorporal approach too, also with two cuffs. This is for the 2 years, and after 2 years, mostly dependent on transurethral manipulation, the long catheter stay after surgery, during surgery, or anything else without a deactivation before. So these two worst case scenarios are existing for erosion. These are different approaches. The tandem cuff, where you can use a smaller tension on the urethra, which brings you in a smaller amount of atrophy from the urethra. And I combine this also with transcorporal placement. So two cuffs were placed to corporal. I close the corpora completely so you can avoid bleeding. And this works really well, even in patients with a severe urethral disturbance with irradiated atrophy urethra before. These are all surgeries I recommend to have and I use, but you also can discuss when you have very old patients in your office a conservative treatment. I have really a lot of patients who are suffering by condoms. They are really working well, and some of my most happy patients are patients who only got some condoms from mine, and they are really happy with that. Also, penile clamps can work. It's a problem because the comfort is not really good. So I use it even when I have patients with a small bladder capacity to train the bladder capacity. They use the clamps, or when I have used Botox, for example, to prepare the bladder for an artificial narrow sphincter, I use these clamps. But it's not good to take them 10 hours a day. It's not so good comfort. So I think condoms works really well. Penile clamps are better for bladder training or for a short duration, just for 2 hours, for example, to go out of home or so, something like that. These are the actual possible treatments for your patients. As an overview, we could talk 5 hours for different evidence for different conditions, anything else, but I think the overview was hopefully helpful for you. I just want to make some views in the future. What is a pipeline? And we have to talk about Euromens. It's a company from France. They provided the Euroactive system. It's the first electrical sphincter. And they had the first results presented and also published. Emmanuel Chartier-Castler from France, from Paris, is performing this study. And now they presented the first follow-up, the first year follow-up. And they have in over 50% of all patients, they have seen, the urine loss decreased with above 50% in all patients. So all patients had an improvement of above 50% urine loss reduction. and they have over 70.5% of patients. Over 75% of reduction of urine loss in 5 patients, so in 5 of 6 patients. And the median PET use decreased from 3.7 to 1 PET a day. This sounds nice, but I think these are results which are not above the recent results about artificial neural sphincters. So I told you before, I won't change my artificial neural sphincter system before I get a new system which is better than the system before. I think these results are comparable to things we have, and in my opinion, it's not a reason for me to go on this device. And interesting is they have a new charge or a new a new raise of 47 million for go on with studies for preparing a clinical trial. And I think it's interesting. With these results, I'm not sure if you can have a reimbursement for these 47 million. And in my opinion, it makes much more sense to go on with the slings, because we are not at the end. We have to. We are able to do it much more better than before. For example, Valker is interesting. Maybe it's coming in the future. Also the Europe, and also we are still working on adjustable smaller slings, which brings us nearer to the sphincter. It makes it able to place them nearby the sphincter like a fixed sling. And I think adjustable slings have a future, and I think in the future they will be from the amount of implantation above the sphincter, because most patients are responsible and available for these devices. And this is the end of my lecture and webinar, and hopefully you enjoyed it. And if you have questions, I'm ready for discussing it with you. Christoph, how are you?
I'm fine, thank you very much. I hope everybody of you enjoyed this this lecture. It was really nice. Thank you very much for that, Fabian. There is one question regarding the ATOMS system. They ask, how is the learning curve for the ATOMS system? Is it easy to learn it, or is it very difficult and you need 50 cases to be very comfortable with that?
I think from these 3 systems, fixed sling, adjustable sling, and sphincter, it's the shortest learning curve. I think after 5 atoms, you are doing it good, perfectly. I think you need maybe 10 to 20 atoms, but after 5 atoms, you do it safely. And I think I started with atoms. We performed about 3 to 4 sphincters a year, and I could do it. But then I add atoms to implemented in my office, and after then I saw an increase of patients, because I had a really huge amount of happy patients with atoms, and this makes me able to become a center. Now we are implanting about 90 devices in a year, and atoms make this possible, because I'm at the beginner. I didn't have this experience with artificial neural sphincter. I started with atoms, and this was the easiest way to go in the stress incontinence. So for sure, it's the easiest way to start with male incontinence surgery.
Okay, thank you very much, Fabian. And there are no more questions. I think your presentation was wonderful, and all questions got answered during this presentation.
For sure.
So it is really good. Thank you very much. Our next webinar will be on the 19th of May with Professor Dr. Ricardo Bauer. The main topic is, what is the right product for which patient? So we will discuss that. And on one point, we offer also workshops with Dr. Fabian Quaiset. And if you're interested in that, please feel free to contact your distributor, and they will help you as much as they can. So I wish you all a good night or a good day when you are from other parts of the world. Good morning and a good working day. So thank you very much, and I hope I see you soon at the next webinar. Thank you very much.
Thank you for sharing the meeting. I enjoyed it. Bye bye.